Right, everyone. I know everyone in the room, but just for the sake of introductions, I'm Emily, and my project is defining the determinants of the omega-3 index among patients with peripheral arterial disease. So just very briefly, I've always been very interested in nutrition, but over the first 2 years of med school, and definitely over the course of this third year with clerkships, that interest has developed more into how can nutrition be used as a method of prevention, particularly for chronic illnesses. And peripheral arterial disease is definitely an example of a chronic illness. So during one of my clerkships, I worked with Dr. Marlene Grenon, who is a vascular surgeon and also a specialist in vascular health, vascular medicine. And she is spearheading a trial that focuses on supplementation with omega-3 fatty acids and how that will affect patients with peripheral arterial disease. So these interests very much aligned with my own, so I was pretty eager to get involved as well as see what sorts of results would come about. So Dr. Grenon couldn't make it today, but we have a couple members of the vascular team, Julia and Karen, so I might turn to them for advice later on. And then also the Viper RX laboratory recently minted, which stands for Vascular Integrated Physiology and Experimental Therapeutics Lab, based at the VA.
Do you have a mascot?
A viper, a snake. Yeah, we're working on it. Yeah. Karen's working on it. I think that's it.
And the stuff animal.
Yeah. Okay. So, also disclaimer: I'm not going to be moving too much right now. We're using hand gestures because I hurt my neck yesterday. So, if I'm a little rigid, that's why. Not because I don't have a personality. I don't. Okay. So the overview of this talk, basically, in the beginning, I'll touch on the basic study elements and what goals we hope to accomplish over the course of the year. Also, I will go not into great depth about long-chain polyunsaturated fatty acids, because that's getting a little bit too into cellular physiology, but we'll talk about the most important aspects. And also, what exactly is the omega-3 index, because it was recently developed, so I'm sure most of us haven't heard about it. We'll talk about basically the public health burden of peripheral arterial disease and what sort of prevalence stats we can expect to see, and then how we're going to execute the study. So I'll start with the omega-3 index. So basically, this is a very simple schematic of a red blood cell, but you could take it to be any cell in the body. But we're focusing on cardiovascular or peripheral vascular disease, so red blood cells it is. Basically, if we look at the membrane, I don't think the pointer's working. Oh, sorry. If we look at the membrane, that's what we'll be focusing on. If you can remember back to cell physiology, it's composed of a phospholipid bilayer. So we have phosphates, and we also have lipids. So lipids are fatty acid tails. And all the different colors and zigzags and shapes and all that up there, they represent different types of fatty acids. So omega-3 fatty acids are just one type. We also have, omega-3 fatty acids are also long-chain fatty acids. There's also short-chain, there's monounsaturated fatty acids. Forget about all those, we're only going to focus on PUFAs, which are polyunsaturated or long-chain. So those are represented by the red squiggly lines, and there's only 3 of those in this schematic. So basically, the omega-3 index is calculated by taking the omega-3 acids in the numerator and dividing them by the total number of fatty acids in the red blood cell membrane. So you get a percentage out of that. The percentage, just for illustration purposes, in the schematic is 4.6%, and that tends to be the average in the American population. As we'll see in the Japanese population or Greenland Eskimos, people that tend to eat a lot of foods that are really rich in omega-3 acids, tend to have numbers higher up in the 10 to 15, maybe even 20%. And as far as I know, this question may come up, I don't think that there's a too high level of an omega-3 index, whereas having low levels, as we'll see in a second, is actually pretty critical and we think contributes to cardiovascular disease. So the overall rationale for the current study that we're undertaking, basically what we're trying to do is define the levels of the omega-3 index among patients with peripheral arterial disease. and then figure out what sort of things determine that index. So is it other nutritional factors? Is it the fact that these people are smoking a lot? Is it their physical activity or inactivity? So on and so forth. So why do we even care? Why is this important? So EPA and DHA, should have mentioned this earlier, are two omega-3 acids, omega-3 fatty acids. And they are extremely abundant in fatty, oily fish, and basically they're our best source for omega-3 fatty acids that make up an aspect of our membrane. Why are they important? Because being so embedded in the cell membrane, they help to modulate activity of membrane proteins, and specifically important for cardiovascular disease are ion channels and inflammatory cell receptors, and then affecting the electrical stability of the myocardium. So previously, randomized trials, RCTs, have evaluated the effects of oily fish and also supplements with fish oil on cardiovascular health among a host of other diseases, but we're only going to focus on CV health here. And they have found an overall decrease in mortality, death from cardiovascular causes, and sudden cardiac death. And then, broadly speaking, a reduction in non-fatal cardiovascular events as well. So, in light of these results, I would say in the last 5 to 10 years, the omega-3 index has been proposed as a new cardiovascular disease factor, in addition to all the ones that we've learned about with the Framingham index. So, long-standing hypertension, smoking versus non-smoking, history of premature cardiac disease, and all those. This one, researchers believe it's a more sensitive marker and actually a better predictor of cardiovascular death. So it's becoming more and more popular to be studied and to be evaluated in patients with cardiovascular disease, and also those without as a prevention tool. So in light of this, things that determine the risk marker have to be identified, because we have some sense of what determines whether someone's going to have high blood pressure, or if someone's smoking, we know that they're going to be at higher risk for vascular disease. So what sorts of things contribute to a greater or lesser omega-3 index? And if so, how do we modify these factors earlier on in life so as to prevent morbid vascular disease? So, study question, just to reiterate, what clinical, anthropometric, and lifestyle factors contribute to the omega-3 index in a very specific subset of patients with peripheral arterial disease? And the reason why we're focusing on this population is, well, number one, that's who Dr. Brunon sees in her clinic. Number two, I'm interested in vascular disease, and also many people at the VA where the study is based have peripheral arterial disease. And the omega-3 index has already been studied in just general populations and people with other coronary disease, so that's why we wanted to take a different spin on this one. So our hypothesis, and I threw some of these in at the end, what sort of things might determine this index? Definitely whether these people are eating a lot of fish. And by a lot of fish, I mean more often than twice a week, 2, 3, 4 times a week. And that's why people in Japan or in Greenland Eskimos are known to eat a lot of very fatty fish. So they're, like I mentioned earlier, their indices are upwards of 10-15%. And then also people are supplementing with fish oil or other ways that they can get omega-3 fatty acids. So those things have been proven to be associated with the index, and kind of made sense to throw in there. Also, smoking, level of alcohol intake, lipid levels, long-term and then short-term, and then diabetes, BMI, physical activity, things that we know determine whether someone has vascular disease. And then I have age and gender in there, but in our study I don't think we're going to focus on it too much because it's pretty constant in our patient population. People at the VA just tend to be older white gentlemen, so I don't think those things are going to determine too much in our study. So what are polyunsaturated fatty acids? Basically, I'm going to use them interchangeably, and they're used interchangeably in mass media. They are omega-3 fatty acids, although omega-3 fatty acids are a big umbrella term. EPA and DHA are essential fats, meaning that we don't make them, our bodies don't make them. We need to supplement them, and that's why taking supplements is so popular nowadays, and that's why if you go to Whole Foods or basically any other store that has supplement aisles with supplements, they're all over the place. Why? So they have proven benefits in cardiovascular disease, as we mentioned before, and also a host of other diseases, neuropsychiatric disorders, primarily dementia, bipolar disorder, Alzheimer's as well, and then osteoarthritis and just generally speaking, inflammatory conditions. So where I mentioned fish, we get our omega-3 fatty acids mainly from fatty fish, and that includes, so not all fish are created equal. We have salmon, tuna, mackerel, sardines, and herring, I think, are the main ones. And canned sources are perfectly fine, whatever other people will say. So where do the fish get their omega-3s? They get them from marine microalgae. So for someone who's vegetarian, if you don't eat fish, what a lot of companies are doing now, pharmaceutical, nutraceutical companies, are isolating the marine microalgae, and then bottling it up for vegetarians and vegans to take. And to my knowledge, I don't know if any head-to-head studies have been done on microalgae supplements versus marine sources of omega-3, so I don't know which one is better or not. From my understanding, any omega-3 supplementation is good. So another source of PUFAs is alpha-linoleic acid, ALAs. They're short-chain fatty acids, and basically once we take them in, they're metabolized and they make long-chain fatty acids in our body. So this is another way for vegetarians and vegans to get their sources. So already went over this. Briefly, how is the omega-3 index calculated? This index is basically developed, I want to say 2002, 2005, so very recently. Blood cells are isolated by ultracentrifugation. Then they're esterified, they're heated, and analyzed by gas chromatography, if any of the chemists are interested. So the index risk zones, these are based on studies that have been done by the index co-developers. So basically we see that I mentioned an average of 4.6%, roughly 5%, that the US and people in Western countries, based on their diets, that's the rate of the omega-3 index. Less than that is relatively undesirable based on rates of cardiovascular disease. Somewhere in the middle is basically, it's a gray zone, rather. We don't know too much about it. And then the higher you are, the better off, and the less likely you are to have a cardiovascular event. So the American diet has a very, very low level on average. These are estimates of EPA and DHA, roughly 110 to 500 milligrams, depending on what study you read. Whereas the American Heart Association, the AHA, prevents for primary prevention, so people who have not had any coronary events or other cardiovascular events, they recommend 1,000 milligrams daily. So either 10 to 2 times more what the average American daily diet is. That changes, so I didn't put any numbers up here, that changes if you've already had an event or already have known documented cardiovascular disease. One of the reasons why we're doing the study is because we know people with vascular disease benefit unequivocally from omega-3 supplementation. We just don't know how much is enough, and that's one of the reasons for studying it so intensely. Fried fish sticks do not count as a source of omega-3 acids, so it needs to be as pure as possible. So switching gears, why are we, yeah.
I just ask one question. How
Yeah.
fluid is the omega-3 index? So if you were to make lifestyle changes, how
Yeah.
quickly would you see a person's index change?
Yeah, so first of all, that's a good question. It depends on how much your supplement, first of all, it depends on what your baseline index level is. So let's say you're starting off at like a 4 or 5% average. It depends on how much you're gonna supplement daily. So if you, let's say you're starting at that level and you're gonna supplement with a gram. I would say roughly 3 to 4 months to see a jump to like 8% or 9% from what I've read,
So
which
it
is
happens pretty
desirable.
quickly.
Relatively quickly, yeah. And that's if you're pretty strict with supplements daily, you're taking, I mean, These supplements are they're relatively easy to take. It's basically just 2 pills that have a gram in them combined. Some people complain that they're kind of fishy, they make you burp a lot, so it just depends on your tolerance level. I don't know about the algae supplements, I haven't tried those myself, but I don't think it's that big of a deal if someone is interested in supplementing, interested in lowering their cardiovascular disease.
I guess more where I was asking that is I'm assuming certain patients that you're gonna see in your clinic
Mhm.
probably have already started some interventions to improve their health, is that?
Not the patients that are being chosen for this study.
Okay.
So I'll touch on that, but yeah, one of the exclusion criteria is actually no prior intake of fish oil, or at least not for some time.
Emily, just coming back to the Greenland thing, I'm just struck by the NCs, but what I don't know much about the cardiovascular epidemiology in that population.
Mhm.
What is it? I mean, cardiovascular disease in Greenland.
Oh,
Is
in
it-
Greenland, oh, sorry, well, I was gonna leave that to the end if we had time.
Oh yeah. Okay.
It's quite low. So that's the story of how the omega-3 fatty acids were even discovered was, so Greenland was a territory of Scandinavian countries. And Danish people, because they're another Scandinavian country, they were really interested in why are the rates of cardiovascular disease so incredibly low in comparison to Western Scandinavian countries. And the researchers knew that the diet was markedly different, but they didn't realize what in the diet was so strange. It happened to be that the Greenland Eskimos were eating a lot of seal, so seal meat and seal blubber is extremely, extremely rich in omega-3 fatty acids. So just by really looking at what they were eating every single day and then also analyzing their blood for analytes, they discovered these then unknown fatty acids. That's PUFAs, exactly. I don't know how tasty seal blubber is. I've never seen it on any menus. Okay, so switching gears, why do we want to study peripheral arterial disease? So basically, I'm sure many of us have encountered it, especially during third year. It is systemic atherosclerosis. So what is atherosclerosis? It's fatty plaque buildup. We're all familiar with coronary vascular disease. This is basically plaques in blood vessels that are conduits that carry blood to peripheral organs. So carry blood to our brain, the carotid arteries, abdominal organs, the liver, the kidneys, and then also to our limbs. So more often than not, I think we recognize peripheral artery disease as causing claudication symptoms, so people having pain when they're walking a certain distance or even at rest. But it can really affect any organ that's not your heart, that's not central. So it has a pretty morbid, the numbers are pretty bad, let's just put it that way. So recent epidemiology has shown that in the States, this is data that's specific to the USA, peripheral arterial disease affects roughly 12% of people that are older than 65, and then the numbers increase for even older people, older than 75. So I'm only quoting the older age people mainly because that's the population that we're studying, and also because PAD takes quite a bit of time to develop, so you can have vascular disease and risk factors for vascular disease like diabetes and metabolic syndrome, but once it's diagnosed as peripheral artery disease, you're at risk for many, many other problems. So once diagnosis is confirmed, either via claudication symptoms, like symptoms with walking, or ABIs, which are ankle-brachial indices, and that's a ratio of systolic blood pressure in your upper extremities and your lower extremities. Once you're diagnosed, the annual mortality is roughly 4 to 6%, so it's not insignificant. And then also your rates for having cardiovascular or cerebrovascular events increase dramatically, so 20 to 60% for MI and for stroke. And then in its most advanced stages, which is critical limb ischemia, which basically means tissue loss and claudication symptoms at rest, your 1 year mortality is roughly 25%, and upwards of close to 50% if you actually require an amputation of your leg. Some more stats on PAD. So in addition to claudication, some of the symptoms that one can experience is impaired ambulation, loss of just functionally moving about, lots of pain, non-healing wounds, ulcers, and even limb loss can be a possibility. And then furthermore, advanced age and then disability among these patients leads to even more morbidity and more mortality. So it's just this never-ending vicious cycle. Moving on. So the Omega PAD trial, I should have mentioned this before, but Dr. Grunon, my main mentor, is basically spearheading this trial to see if high-dose omega-3 fatty acid supplementation, if that has, what effects that has on people with peripheral arterial disease. So I mentioned that primary prevention, the recommended dose is roughly a gram a day. Right now, she's testing 4.4 grams per day with these patients who have diagnosed symptomatic, meaning they have claudication symptoms, peripheral arterial disease. So they're taking these dosages over the course of a month, and they get a whole slew of baseline testing done initially. Then, if they're randomized to the group that's gonna take fish oil, they come back a month later, go through the same exact test. Their endothelial function is tested, their inflammatory tests, blood analyses are done, as well as food questionnaires, and we compare the two. Okay. So I should say at this point, I'm going to be using data from this trial to evaluate what are the determinants of the omega-3 index. So we haven't actually pinpointed whether we're going to only focus on cross-sectional data at baseline, or if we're going to compare the pre and post supplementation groups. And mainly that has to do with the loss to follow-up, the number of patients that we're going to get back once the month-long intervention has taken place. So the overall goal of this clinical trial is to see if omega-3 fatty acids confer any sort of improvement in arterial endothelial cell function and inflammation. My study is personally not going to be looking at these facts, mainly because they've already been studied and they've already been published. So we know that omega-3 fatty acids lead to one step back. Higher levels of omega-3 fatty acids, as evaluated by the index, are related to lower levels of inflammation, systemic inflammation, and also better endothelial function. So, given that that's been established, we want to know how can we affect this risk factor earlier on. Right, and the whole purpose of that is because patients with peripheral arterial disease are taking so many medications and are at risk for so many different interventions, primarily surgical. So we want to know, is a natural supplement, is that better than taking a statin? Is it better than suggesting revascularization? Can it necessarily be an alternative? Can it be an adjunct? So these are just some questions that have been looming for many years. Talked about this a little bit. So the inclusion and exclusion criteria, we've touched on this. Basically, we're recruiting patients from the vascular clinic over at the VA. They initially wanted to recruit both men and women, but given the veteran population, we're basically looking at older white men, like I mentioned before, over 50, but they tend to be in the late 60s, early 70s. And a whole slew of exclusion criteria, but basically people who have inflammatory disease or other systemic diseases are not allowed to be studied, mainly because they have so many other risk factors that can confound the results. Oh, and I should mention there are a couple arms to this study. So there's a randomized arm, so people who have symptomatic PAD and they are getting, they're either randomized to getting a supplement versus not. And there's also a cross-sectional arm, so people with peripheral arterial PAD who have more morbid disease, I should say. So people with critical limb ischemia, they're kind of ushered into a different category, and they're not supplemented. So we're just interested in studying them for the sake of comparison. And then also this is actually one of the main reasons why the study is taking a little bit longer, to my advantage, because I'll have a lot of work to do over the course of the year. We're trying to recruit as many control patients as we can, and that's proving to be extremely difficult at the VA because by controls we mean people who don't have evidence of PAD or vascular disease. And yeah, that's not that easy to find at the VA. So we're turning to the orthopedic clinic or the ophthalmology clinics, but you just, yeah. I don't know why I'm so surprised, but basically everyone has vascular disease. So at the moment, well, I'll touch on this later. At the moment, we have roughly 80 or so patients in the randomized group, some more in the cross-sectional group, and controls we have maybe 15 or 20. So we're just actively trying to get as many as possible. So this is just a list of some of the measurements that we're taking that'll help in my search for what determines the omega-3 index. So statistical analysis, I touched on this a little bit. We're basically trying to get as many patients as possible with PAD and then controls. And then we're going to run univariate analyses on these, on the things that we think will determine the index. And then eventually we might move on to a multivariate regression model, depending on how many co-founders and covariates we identify in the initial analyses. So do we have a little bit of time, or we're running a little over? I was just going to touch on the story about Greenland Eskimos, but I already did. They eat seal blubber. So we see a lot of things about the omega-3 fatty acids in the news, fact or fiction. So I just wanted to shed a little bit of scientific light. Hopefully people are a little bit more believers in this now than they were before. Question? Yeah.
I'm not sure if I missed it, but you said that the primary outcome was endothelial function, right?
In the main trial,
Mhm.
but for my study, it's going to be the omega-3 index.
Okay.
Yeah.
And in that trial, how did they measure endothelial function?
Right, so I didn't go into this too much because it was a little bit outside of the scope. Endothelial function is measured by FMD, flow-mediated vasodilation. So it's a non-invasive, ultrasound-guided way of measuring the brachial arteries. Well, you can actually measure any artery, but it's validated in the brachial artery. So basically what you're doing is measuring the diameter of the brachial artery, then you occlude it with a blood pressure cuff for about 5 minutes. And then after the 5 minutes have gone by, you release the cuff, and that's supposed to induce a lot of blood flow, and so that blood flow is meant to increase the diameter of the brachial artery. And so you measure that, and the difference between the brachial artery post and pre is somehow supposed to give you a measure of endothelial function. Mainly because the endothelial cells, sorry, there are a lot of long words in this talk. Endothelial cells are the ones that line blood vessels. So if you can imagine it like a hollow tube, the innermost lining are endothelial cells. So if they're functioning well, as they should, then they are, the substances that they release, they're the main vasodilators. If they're not functioning, or if they're impaired for whatever reason, whether there's fatty plaque buildup, people smoke, so on and so forth, they're not going to vasodilate as much, and your FMD, that objective measure, it's going to be smaller.
So you're assuming that physical, like circumferential pressure on an artery induces vasoconstriction, and by letting go of that pressure, it would induce vasodilation?
Not the letting go, but once you let go, the flow of blood. The increased flow of blood is supposed to interact with the endothelial cells to make them secrete substances that are known to vasodilate. It's a little complicated to me. Well, yeah. Anything else?